The field of ALL is generally moving towards integration of these very effective monoclonal antibodies into the frontline therapy. So, when these agents were first developed, the standard would still be to give just chemotherapy alone in the frontline setting, and then if a patient were to relapse, then you would give them either inotuzumab or blinatumomab, and then if they were relapsed from them, you give them the other agent. But I think that sequencing these therapies doesn't really lead to the cure rates that we want to see for these patients. So the challenge is just to find the safe doses of these drugs to integrate into frontline therapy to really increase the likelihood of cure. And I think we're seeing this not only in our studies, but there's a number of other studies from other groups and cooperative groups that are evaluating blinatumomab and or inotuzumab in the frontline setting. I think that as we see more of these data emerge, I think this will emerge as more of a standard to use these agents in the frontline setting. And I think that what we'll see is the standard will be chemotherapy with these novel monoclonal antibodies, and then maybe in later salvage, then we would do CAR T cells or other cellular therapies or transplant if needed in the salvage setting, but not necessarily in first remission. I think we hopefully can also overcome the need for transplant by giving these very more effective agents in the frontline setting along with chemotherapy.